Good morning, ladies and gentlemen. The lecture for today is the eczematous disorders. Since I've already given lectures on atopic dermatitis, on irritant and allergic contact dermatitis, so these topics will not be included in this lecture. All the other forms of eczema will be discussed subsequently. Definition and nomenclature. Eczema is a clinical and histological pattern of inflammation of the skin that is seen in a variety of dermatoses with wide range of different etiologies. So eczema is both a clinical term as well as a histological term. Clinically, the eczematous dermatoses are characterized by the variable intensity of itching, soreness, dryness, erythema, excoriation, exudation, fissuring, hyperkeratosis, lichenification, papulation, scaling, and vesiculation. So in this paragraph, you can see that I have used all the different type of presentations which we see in different type of dermatosis. So eczema can be summarized by saying that eczematous lesions have a feature of all the other dermatoses. Eczema can be acute, it can be chronic. If it is acute, then it will be having acute presentations like erythema, excoriation, exudation, crusting, itching, soreness. And when it is chronic, it will be having chronic features like hyperkeratosis, lichenification, papulation, and scaling. In general terms, the eczema tend to be ill localized, not very well localized, with variable clinical features. Acute eczemas tend to be edematous and exudative, and chronic eczemas are characterized by dryness and thickening or lichenification. Histologically, the characteristic histological finding in all eczemas is spongiosis, which is the intercellular edema with varying degree of acanthosis and hyperkeratosis. Incidence and prevalence. The point prevalence of all eczemas is around 18 per 1,000, 7 of whom have atopic eczema. So atopic eczema is the most common type of eczema which we encounter, which comprises of almost half of all the other eczemas. Hand eczema, dyshydrotic eczema, and nummular eczema each account for about 2 per 1,000. The management of exogenous eczema is to remove the cause if possible, whereas the endogenous eczemas more often require the pharmacological intervention. Eczema is the commonest cause of erythroderma. We are going to discuss erythroderma in this lecture. 67% of the eczema cases are classified as endogenous and 13.7 as contact or exogenous eczemas. So the endogenous eczemas comprises of more than 70% of the cases. Classification of the principal forms of eczema. So this classification of eczema is based on whether the cause of eczema is exogenous or endogenous. So the exogenous eczemas include the allergic contact eczema, the irritant contact eczema, the photoallergic contact eczema, eczematous polymorphic light eruption, dermatophytitis, infective eczema, and post-traumatic eczema. While the endogenous eczema, which is the bigger group of eczemas, comprises of atopic eczema, ASTEATOTIC eczema, superficial scaly dermatitis, juvenile plantar dermatosis, NUMMULAR or DISCOID eczema, seborrheic eczema, venous eczema, and the uncommon type of eczemas like eyelid eczema, P. alba, and eczemas associated with systemic disease. Age and sex. Most cases of eczema in infants and young children are due to atopic dermatitis. Perioral eczema is common in children with atopic eczema. Hand eczema is also common in atopics and uncommon in non-atopic children. Several specific patterns of eczema are found in children. For example, juvenile plantar dermatosis in juvenile ages and napkin dermatitis in young infants. Complex and atopic eczema is less common in elderly patients, while NUMMULAR and ASTEATOTIC eczema of leg are common presentation in elderly males in winters. Pathophysiology. The interaction of trigger factors. Trigger factor can be any allergic factor like dust, like soap, detergents, or any other chemical. The interaction between a trigger factor, keratinocytes, and T lymphocytes seems to be particularly important in causation of most of the eczemas. Eczemas may also be provoked by non-allergic manners, as in irritant contact dermatitis. So in irritant contact dermatitis, three predominant processes are a disturbed barrier function of the stratum corneum. Number two, epidermal cell change and release of inflammatory mediators and cytokines due to the irritant material in contact with the skin. Certain irritants may provoke a chronic reaction in which an effect on epidermal cell turnover predominates, leading to lichenification. After activation of immune pathway by cytokines, the accumulation of inflammatory cells lead to morphological changes that are apparent histologically as well as clinically. So this is the main histological hallmark of all eczema, that is spongiosis. Spongiosis is the intercellular edema, epidermis and other epithelial structure. The spinous cells or keratinocytes, which are polygonal in shape, are connected with each other by desmosomal junctions. In usual histology, these desmosomal junctions are not visible. But due to the intercellular edema, these intercellular bridges become conspicuous in spongiosis. And because of the spaces that are created between the keratinocytes, the inflammatory cells from the dermis, they have an opportunity to enter the epidermis, and this phenomena of entering of inflammatory cells in spongiotic epidermis is called as exocytosis. In acute dermatitis, there is spongiosis along with several intraepidermal vesicles containing serum and fibrin. There is no other cause of intraepidermal vesiculation other than acute eczema. This is another view of two intraepidermal vesicles with lymphocytes, and you can see spongiosis in the epidermis as well as the lymphocytic exocytosis. Subacute eczema has few features of acute eczema and some feature of chronic eczema. As far as the features of acute eczema are concerned, there will be spongiosis, lymphocytic exocytosis, and some intraepidermal vesicles. And as far as the features of chronic eczema is concerned, there will be epidermal hyperplasia with elongation of rete ridges and along with parakeratosis and hyperkeratosis. This is a subacute eczema. You can see spongiosis with some form of vesicles and irregular epidermal hyperplasia. Now the chronic eczema or the chronic lichenified dermatosis. This is characterized by thick hyperkeratosis, hypergranulosis, and epidermal hyperplasia. Spongiosis may or may not be visible in such cases. This is a chronic lichenified eczema. So this pattern is different from psoriasis. In number one, there will be hyperkeratosis rather than parakeratosis. The granular layer will be intact and epidermal hyperplasia will be irregular. Furthermore, in psoriasis, there are Monroe abscesses and spongiform pustules of Kogoj, which will not be seen in chronic lichenified eczemas. Clinical features. History. The hallmark of eczema in terms of symptoms is pruritus, which can be disturbing. In some acute forms of eczemas, the symptom is not pruritus, but it is soreness or pain. It may be important to note that occupation and recreational activities affect the symptomatology of eczema. Secondary dissemination. This is an important phenomenon to understand. A characteristic feature of eczematous inflammation is its tendency to spread far from its point of origin and become generalized. This phenomena is often termed as autosensitization or autoeczematization, and the distribution is usually symmetrical. So it means that even if there is a contact eczema on the face, there is a tendency of eczema to spread to neck, chest, and back because of the phenomena of autosensitization or autoeczematization. The course of secondary eruption depends largely on the progress of primary lesion. If the primary lesion remains acutely inflamed, the eruption increases in severity and becomes generalized and evolve into erythroderma. So similarly, the secondary dissemination can ultimately lead to erythroderma if the acuteness of the inflammation or the reason of the initial cause of eczema is not taken care of. Now, another term which need to be understood is condition hyperirritability. This refers to a phenomena whereby an area of inflamed skin on one part of the body results in generalized hyperirritability of the skin. So this is not the secondary dissemination, but it is just an increased irritability of the distant portion of the skin. The angry back phenomena is a similar condition hyperirritability in which a strong positive patch test response can increase the percentage of false positive reactions on the back. So one intensely false positive test will result in, one intensely positive patch test will result in few more false positive patch tests. Circulating activated T lymphocytes are increased in number in condition hyperirritability that suggests that an abnormal cell-mediated immune response against autologous skin antigens. Complications and morbidities of eczema. There is increased risk of both bacterial and viral secondary skin infections in eczemas. And eczemas tend to follow chronic and relapsing and remitting course. Investigations. Most eczemas can be diagnosed clinically. It can sometimes be helpful to measure total serum IgE level. However, serum IgE levels does not correlate with any form of eczema. Secondary infection can be confirmed by taking swabs for culture and sensitivity. When dermatophytes are suspected, then QOH preparations should be examined. Microscopy or dermoscope examination can be helpful to confirm the diagnosis of scabies. Biopsy can occasionally be helpful in confirming the eczematous nature of eruption, and sometimes we have to differentiate eczemas from cutaneous T-cell lymphoma and psoriasis. Patch testing. Routine use of patch test is not indicated. The investigation is more important in atypical or asymmetrical eruptions, especially in dermatitis affecting the face, hands, and feet. Management. Take history of previous treatment experiences. Keep in mind the attitude of patient to the risk and potential adverse effect associated with any treatment that may be required. A considerable variety of effective treatment modalities are available. These range from conservative approaches such as rest and emollients to more hazardous treatment such as phototherapy and systemic immunosuppressants. When extrinsic cause is identified or suspected, then this cause should be removed, otherwise eczema is not going to get better. Psychological support is an important aspect of management of all stages of eczema. Management of acute eczema. For acute or exudative eczema, adequate rest is essential, and affected leg or hands should be elevated and used as little as possible. Highly vesicular and exudative eruptions such as pompholyx benefits from soaks by 1:10,000 potassium permanganate or aluminum acetate solution. Sometimes we don't do soaks, but we do wet soaks or wet dressings. In wet dressings, the gauzes are soaked in any of the above solutions, also including normal saline, and the gauze is spread over the acute eczema and the patient is asked to lay down on the bed. As the gauze dries, it is again made wet by the solution and reapplied. So this process is continued till the exudation stops. Then liberal application of bland emollients. Moderate or potent topical corticosteroids are generally used for a few days. Topical calcineurin inhibitors such as tacrolimus or pimecrolimus is used. When practical, tubular bandage can be used to keep the topical medications in place. The wet wrapping techniques, in which a layer of wet tubular bandage is covered by a dry layer. First of all, ointment is applied, then a wet gauze is applied on the ointment, and this is covered by a dry gauze dressing. Mild or moderate corticosteroids should be used for face and genital areas. Potent or very potent topical steroids are used for acute pompholyx on the hands and feet. When secondary infection is present, oral antibiotics must be given. Topical preparations containing antibiotics or antiseptics in combination with corticosteroids is helpful in many forms of acute eczemas. Such preparations are easily available in market. Excoriation can be reduced further by sedative antihistamines like hydroxyzine, which is available in Pakistan as Atarax, and additional hypnotics may be used for a few days to ensure sleep and reduce the symptomatology. Then management of subacute eczema. The perpetuating factors such as exposure to sensitizing agents and treatment compliance should be considered. Dermatology review or admission to the hospital is often helpful. Paste bandage are of particular value in occluding areas that are frequently excoriated. Different kinds of paste are used, like urea paste or zinc paste. Corticosteroids under polythene occlusion for a few days may be helpful at this stage to reduce pruritus. Topical immunomodulators such as tacrolimus or pimecrolimus are alternates to topical corticosteroids. Then the management of chronic eczema. First-line therapy of chronic eczema is frequent application of emollients and avoidance of irritants such as soaps and relevant allergens. Daily application of corticosteroids is required to treat flares, and choice of potency is determined by eczema severity, the site, and the patient's age group. Once the eczema is controlled, then twice weekly application may be needed to maintain remission. Calcineurin inhibitors are applied in similar way. Coal tar or shale tar, ecthiamol, usually applied as creams, can be soothing and reduce pruritus. Occlusive dressing and bandages may be useful. Sometimes we use other keratolytic agents like salicylic acid for hyperkeratotic eczemas. To reduce the pruritus, different agents are used in topical formulations that include sulfur, menthol, and phenol. Narrowband UVB, Psoralen and UVA, PUVA, and UVA1 are all effective in treating chronic intractable pruritus and chronic eczemas. Systemic corticosteroids act rapidly and improve symptoms in a day or two whenever there is its requirement. In most severe cases, oral immunosuppressive therapy is required, and these include methotrexate, azathioprine, and cyclosporin. L-tretinoin and oral retinoids have recently been licensed for use in chronic hand eczema after large randomized controlled trials. Then, a common subvariety of eczema, which is the nummular or discoid eczema. Nummular dermatitis is characterized by circular or oval plaques of eczema with clear demarcation, or you can say the coin-like or disc-shaped plaques. It tends to be a chronic problem that undergoes relapses and remissions. Prevalence of nummular dermatitis is 2 per 1,000, and it tends to affect women earlier than men. Some authors find a high incidence of atopy in such patients. Causative organisms. Some authors have stressed a role of infections like staphylococci. If it is not the cause, it can be a reason of secondary dissemination. Then environmental factors include allergic contact dermatitis in about a third of patients. Dry skin is sometimes associated with nummular eczema in elderly. Oral gold therapy in form of sodium or thiomalate and auranofin, which causes discoid eczema in dose-dependent manner. Presentation. The diagnostic lesion of nummular dermatitis is a coin-shaped plaque of closely set, thin-walled vesicles on an erythematous base. In acute phase, the lesions are very exudative, crusted, and pruritic. They progress towards less vesicular, ring-shaped annular lesions. As they fade, they leave dry, scaly patches. After any period between 10 days and several months, secondary lesions occur, often in mirror image configuration on the opposite side of the body. There are various clinical variants of discoid eczema. Exudative nummular dermatitis, characterized by leakage of serous fluid and crust formation. This is the more severe end of the spectrum and require oral antibiotic treatment. Then dry nummular dermatitis, which consists of multiple dry, scaly, round, oval discs on arm and leg, and this is usually resistant to treatment. Then nummular dermatitis of hands occur on dorsa of hands and sides of the finger, often a single plaque. Atopic history is quite frequent. Then the last is exudative discoid and lichenoid chronic dermatosis. It is, as the name signifies, has a mixed picture between exudative and lichenoid lesions. After a chronic course of month and year, the condition ends with a spontaneous cure. The common differential diagnosis of discoid eczema are tinea, psoriasis, and pityriasis rosea. All forms of nummular dermatitis are chronic with partial remission. Relapses occur with variable intervals, most often during colder months of the year. Investigations. Irritants and occasionally sensitizers may provoke this type of response. When the history suggests this, patch testing should be performed, and common detected allergens are chromate, nickel, cobalt, and fragrances. Management. General considerations such as avoidance of irritants and removal from a stressful environment. Then emollients and topical corticosteroids are useful. Steroids can be potent or very potent and needed to be combined with topical antiseptic or antibiotics sometimes. Combination of tar and dilute corticosteroid prove useful. Course of broad spectrum oral antibiotics such as clarithromycin is often helpful in exudative phases of discoid eczema. Then asteatotic eczema, which is also called as eczema craquelé. This eczema develops in very dry skin, usually in elderly, and affect the leg, arm, and hand. A characteristic crazy paving pattern is observed on the legs. Multiple cracks in the dry skin. It may flare during the winter due to reduction in humidity. Elderly people are predominantly affected and no gender predominance, and all ethnicities are affected. Asteatotic eczema is a presenting sign of mixed edema and also due to zinc deficiency. Predisposing factors. Asteatotic eczema is common in patients having naturally dry skin and lifelong tendency to chapping. A further reduction in lipid in the stratum corneum occur with age, illness, malnutrition, and hormonal decline. Increased transpiration relative to environmental water content, loss of integrity of horny layer or the barrier dysfunction, chapping and degreasing by industrial or domestic cleanser and solvent. Those who have a habit of frequently washing their hands and feet tend to develop eczema craquelé earlier. Low environmental humidity and dry cold winds also predispose. Repeated minor trauma leading to inflammation is also one of the predisposing factors. Other environmental factors include diuretics, cimetidine, and topical corticosteroids have also been reported. Clinical features. Irritation is often severe and worse with change of temperature, particularly while undressing at night. Condition occurs predominantly on the legs, arms, and hands. The asteatotic skin is dry and slightly scaly. Finger pulps are dry and cracked, producing the distorted prints called as the parchment pulps. On leg, the superficial markings is more marked. The superficial skin markings become more marked, and this is called as the crazy paving pattern. Clinical variants. Cases have been reported in association with malignant lymphoma, angioimmunoblastic lymphadenopathy, anaplastic gastric adenocarcinoma, and spheroidal cell carcinoma of the breast. Complications. Secondary infection is possible. Disease course and prognosis. Without treatment, condition is chronic, relapsing in each winter and clearing in summer. Scratching, rubbing, and chronic irritant and sensitizers cause further eczematization and infection. The first line management is keep the environment humidified and avoid sudden changes in temperature. Use emollients with or without urea, bath oil and soap substitutes. Third, mild topical corticosteroids, picrolimus 1% cream can be used. Patient should be asked to avoid areas where there is chances of getting further dry skin and avoid dust and environmental exposure. And patient should be advised to wear only cotton clothes and no nylon or woolen clothes must be worn. Eczema of the hands. Dermatitis in this case is mainly confined to hands. It has particular impact on quality of life due to its effect on dexterity, that is fine work that is performed by the hands. The appearance, as hands are obviously seen by everyone, and social functioning. Classification is based partly on etiology and partly on morphology. Several different morphological patterns are seen clinically, but some of these entities can have different causes. Conversely, a single cause can sometimes produce several different morphological patterns. Most cases of hand eczema have a multifactorial etiology. This not only makes treatment difficult, but it can also cause considerable problems in medico-legal cases. So the morphological classification of hand eczema includes apron eczema, chronic acral dermatitis, nummular dermatitis, fingertip eczema, the gut eczema, hyperkeratotic palmar eczema, pemphigus, recurrent focal palmar peeling, ring eczema, wear and tear dermatitis, and other patterns which include patchy vesiculo-squamous. Etiological classification include the exogenous and endogenous causes. Exogenous causes include contact irritants like chemicals, soaps and detergents, and physical like friction, trauma, and cold air. Contact allergens like chromium, rubber, or seafood. Ingested allergens, for example, drug, possible nickel and chromium, infections, and secondary dissemination. Endogenous causes of hand eczema include idiopathic, which include the discoid and hyperkeratotic palmar eczema, then atopic dermatitis, psychosomatic stress aggravating dermatitis, and dishydrosis because of increased sweating, which aggravates the hand eczema. Incidence and prevalence. Virtually everyone suffers from mild dryness and chapping of hand at some time or another. The crude incidence is around about 5.5 cases per 1,000. Hand eczema is more than twice as common in women. Hand eczema is a common problem in all ethnic groups. It is common in people with previous history of atopic dermatitis. Many patients give a convincing account of exacerbation at times of acute anxiety and frustration or grief. Role of stress in hand eczema is difficult to evaluate as the disease itself is stressful. Occasionally, there is history of premenstrual flare and deterioration during pregnancy. Contact irritants are commonest exogenous causes of hand eczema, but contact allergens including chromate, epoxy glue, and rubber are also important. Oral ingestion of allergens such as nickel, chromium, or balsam of Peru have been reported to provoke or aggravate hand eczema. The problem of occupational eczema in hairdresser, fish industry, farmer, construction worker, dental, medical personnel, and metal workers and caterers. Patient occupation and recreational activities indicates the potentials of contact allergies in hand eczema. So the clinical variant, the hyperkeratotic palmar eczema is characterized by scaly, fissured, hyperkeratotic patches on palmar surface of the finger. The pemphigus hand eczema is characterized by small vesicles, tense vesicles on the palm and soles in which edema fluid accumulate, sometimes bulliform, and account to 5 to 20% of hand eczema cases. Chronic recurrent vesiculation without periods of remission may be termed as chronic vesicular dermatitis. Apron eczema is a type of eczema in which the proximal palmar aspects of two or more adjacent finger and contiguous palmar skin over metacarpophalangeal joint is involved in continuation just like an apron. Chronic acral dermatitis characterized by hyperkeratotic papillovesicular eczema of hands and feet associated with high IgE and subjects with no personal or family history of atopy. Nummular eczema we have discussed. Fingertip eczema. This is the eczema which involves the fingertips of all the fingers. Skin is dry, cracked, and breaks down into painful fissures. The condition is worse in winter and improves on holidays. Fingertip eczema is usually a cumulative irritant dermatitis. Condition mainly involves the dominant hand, but allergy to onion, garlic, and other kitchen products held in non-dominant hand is also cause of hand eczema. Patchy vesiculo-squamous eczema. This is a mixed, irregular patchy pattern of vesiculo-squamous lesions. Recurrent focal palmar peeling. It is a common phenomena seen during the summer months with small areas of superficial white desquamation develop on sides of finger and palms or on the feet. This appears abruptly and expands before peeling off. There is little or no irritation and also seen at change of seasons and a relatively benign dermatosis. Ring eczema is characterized by eczema, particularly in women, and it starts soon after marriage or childbirth. An irritable patch of eczema begins under a ring. Complications. The hand eczemas are usually complicated by secondary bacterial infections. The disease course, if the allergen is not identified, the course is prolonged. But if it is identified and removed, then the prognosis of hand eczema is good. Atopic hand eczema probably has a worse prognosis. Management. The chronic hand eczema, or the eczema that persists for more than 6 weeks, is treated by frequent application of emollients and use of topical corticosteroids wherever indicated. Soap substitute should be used in spite of the regular soaps. Gloves should be worn to avoid all sorts of irritants. Rubber gloves are generally given good protection for housework. In patients with rubber allergy, polyvinyl chloride house gloves should be worn. Barrier creams are used in attempts to prevent hand eczema of occupational origin. For severe hand eczema, potent or very potent topical corticosteroids may be needed. And sometimes in unresponsive cases, steroid under occlusion may be used. In hand eczemas not responding to topical corticosteroids, diagnosis to be reviewed, particularly in regard with tinea. Topical calcineurin inhibitors are other options. Tar paste have been used for chronic unresponsive cases, and salicylic acid ointment is also helpful to remove the hyperkeratosis and scaling. Sometimes localized areas can be injected with triamcinolone 10 mg per ml. Other treatments include Grenz rays for Pomfalex, iontophoresis. At present, retinoid alternative, L-tretinoin, is only licensed systemic treatment for chronic hand eczemas. Other alternates include acitretin, cyclosporin, azathioprine, methotrexate, PUVA, hand and foot PUVA, or UVB therapy. Acute hand eczema, it is important to eliminate the precipitating cause. Emollients are to be applied, and hand soaks should be done. Systemic antibiotics may be required. So I will be discussing this and other topics related to eczema in my next lecture. So thank you very much for the time being.